Hello, my name is Walter Kucharczyk. I'm a neuroradiologist at the University of Toronto, and my lecture today is on the imaging of prion diseases. Prions were discovered by Dr. Stanley Prusner, a neurologist at UCSF. He defined prion as a proteinaceous infectious particle that lacks nucleic acid, and his hypothesis was that prions multiply in an incredible way. They convert normal proteins into dangerous ones by simply inducing the benign protein molecules to change their shape or conformation. These conformationally altered proteins then can cause a variety of communicable and inherited disorders. Prion diseases are rare, untreatable, and fatal. For his work, he was awarded the Nobel Prize in Medicine in 1997. At the bottom right is a picture of Dr. Prusner. The total incidence of all the prion diseases now exceeds more than 2 cases per million population per year, and this incidence per unit population has more than doubled over the past 15 to 20 years. Of the different types of prion disease that exist, by far the most common is sporadic sCJD, which accounts for over 90% of all cases. The other types are fatal insomnia, Gerstmann-Straussler-Schenker syndrome, and Kuru. These diseases exist in sporadic, inherited, and acquired forms. With respect to the acquired forms, almost all of them have been eliminated because of various public health measures that have occurred over the past 20 years. There were approximately 400 cases of iatrogenic sCJD that had occurred due to dural grafts, corneal transplants, surgical instruments, cadaveric pituitary hormone extracts. The variant form, or also known as the mad cow disease, there are about 200 cases worldwide, but with changes in the practice of raising cattle in the UK, this has been virtually eliminated. And there was this peculiar disease called Kuru, which existed in an isolated tribe in the highlands of New Guinea, which practiced ritual cannibalism. When that ritual cannibalism was banned, the disease was eliminated. The normal prion protein is present in everyone and is designated as PRP superscript C. The prion protein is found mostly in brain and lymphoid tissue, and it is known to have 253 amino acids. The gene for encoding this protein is known. It is located on the short arm of chromosome 20. In sCJD, the abnormal prion protein has exactly the same amino acid sequence as a normal prion protein, but it has a different shape. Shape is designated as conformation, and it's designated as PRP superscript SC. Interestingly, the amino acid at position 129 or codon 129 seems to have a strong influence on whether the patient is susceptible to the variant form of sCJD. The amino acid at this position can either be methionine or valine, and over 99% of all variant sCJD cases, all mad cow cases, have been homozygous for methionine at position 129, designated as M/M. This slide demonstrates how a person can acquire the abnormal prion protein. There are 3 pathways. It could be through infection, transmission from a carrier, through a blood transfusion, through a tissue extract, or through contaminated instruments, by inheritance from a family member, or the most common pathway is a spontaneous mutation of the prion gene, where the abnormal protein is produced at some stage in one's life, not the normal protein. Through each of these pathways, the abnormal prion protein enters the body, and once in the body, it acts on other normal prion proteins to convert them into the abnormal prion proteins by changing their shape or their conformation. Once the shape is changed, once the conformation is changed, the protein doesn't function properly. It's thought to be a cell membrane protein. The cells become dysfunctional. They die. They end up with spongiform little lesions in the tissue, little holes that resemble the holes in a sponge in the tissue. The disease is expressed, and the patient suffers the consequences, ultimately being a fatal outcome. Sporadic sCJD is by far the commonest of all prion diseases, accounting for over 90% of all cases. The etiology is of unknown cause. It's a disease of older adults and has a mean survival time from diagnosis of about 6 months. Dementia is usually the dominant clinical finding, especially rapidly progressive dementia. Patients also suffer from involuntary movements, especially myoclonus, ataxia, and or cortical blindness. The testing usually involves EEG, CSF, and MRI. EEG has relatively low sensitivity. CSF testing for 14-33 protein was the mainstay of diagnosis prior to the new RT-QuIC test, which was developed in 2011. The RT-QuIC test has a high sensitivity and is almost 100% specific, so it is the diagnostic test of choice. MRI will be discussed on the next slides. The definitive diagnosis is made by biopsy, showing spongiosis, gliosis, and neuronal loss, and by immunocytohistochemistry for the prion protein. With respect to imaging, MRI is by far the test of choice, and the best technique is diffusion-weighted images. Contrast-enhanced images should also be performed to rule out other pathologies. To date, there's never been a case of sCJD that demonstrates enhancement, so if the lesion enhances, it's not sCJD. The diagnosis is excluded. The findings are that only gray matter is involved. You get high signal intensity in the affected areas that have restricted diffusion. There's no mass effect and no enhancement because there's no inflammatory response. The diffusion-weighted changes occur early and stay positive, probably up until close to the time of death. Some papers that have done diffusion-weighted images with different B values have indicated that diffusion-weighted images with high B values are probably more sensitive and show the lesions earlier than with conventional B values, for example, with a value of 1,000. The disease is usually bilateral, but it can be unilateral, and asymmetric cases are not rare. The most commonly affected areas are the caudate head, the putamen, and the cerebral cortex, and occasionally the thalamus. The findings in the other prion diseases are thought to be similar, but there are very few case reports. The classic appearance of sCJD on MRI is shown here, and it consists of hyperintense cortical ribbons, most obvious in the diffusion-weighted images, and hyperintensity in the basal ganglia. This occurs in about 70% of cases of sporadic sCJD at presentation. This slide demonstrates the conspicuity of the lesions on diffusion-weighted images comparing B values of 1,000 to a B value of 2,500. You can see although the lesions are apparent on both, they are more conspicuous with the higher B value. Some people have proposed, therefore, to use higher B value diffusion-weighted images in equivocal cases. In 15 to 20% of cases, only the cortex is abnormal when the patient initially presents. This is illustrated in this case here. Subsequently, as the patient is followed, the basal ganglia may become abnormal at a later stage. In another 15% of cases, only the basal ganglia are abnormal and the cortex is normal. that type of case is not shown here. In a very small percentage of cases, the MRI is completely normal. In the first MRI descriptions of the variant form of sCJD, mad cow disease, approximately 18 to 20 years ago, there was a stress put on the finding of hyperintensity in the pulvinar on diffusion weighted images, and it was thought to be a relatively specific sign for variant sCJD in the proper clinical context. However, it was subsequently recognized that the pulvinar can also be involved in sporadic sCJD, but in the sporadic form, the pulvinar lesion is always less hyperintense than the striatal lesion, compared with variant sCJD, where the pulvinar lesion is brighter than the striatal lesion. This next series of slides shows progression of the disease. This is a 40-year-old who presented with myoclonic jerks. On your far right, you see the diffusion weight images, in the middle, the flare images, and on the far left, T2 weight images. On the diffusion weight images, you can see bilateral scattered cortical ribbons that are hyperintense in the parietal and in the occipital regions. 10 days later, the cortical ribbons are more pronounced, and now there is evidence of a subtle lesion on the diffusion weight images in the caudate head. By day 36, the cortical ribbons have progressed, and now there's evidence of involvement of the caudate and putamen on the left, and more extensive involvement of the cortex. At this stage, the patient was vegetative and never recovered from the vegetative state. Different clinical subtypes of sporadic sCJD have been described. The most common of these is the Heidenhain type, initially described in 1929. And in this type, visual signs or symptoms occur first and continue to be prominent throughout the illness. So it's a clinical diagnosis, and it accounts for anywhere to 5 to 20% of all sCJD cases. Most patients first present to ophthalmologists before a sCJD diagnosis is established, and in theory could be a risk of procedural cross-contamination to other patients. Example, if there's cataract surgery or corneal transplant surgery. It tends to have a more rapid progression, approximately 5-month survival versus 6 to 7-month survival. And the MRI findings are similar to other types of sporadic sCJD, but it's a very high percentage of cortical lesions visible on the diffusion weight images in the occipital and visual cortex. These are diffusion weighted images in a patient with Heidenhain type of sCJD. Most patients with Heidenhain type do have lesions in the parietal occipital cortex, but lesions in the parietal occipital cortex do not automatically make it a diagnosis of Heidenhain sCJD. By definition, the Heidenhain type is when visual loss precedes other symptoms. It is a clinical diagnosis. In the appropriate clinical context, the MRI findings are highly accurate in establishing a correct diagnosis with a very limited differential, the differential being multifocal subacute infarcts, encephalitis, and some paraneoplastic syndromes. The best test is CSF sampling using the RT quick test, which has nearly 100% specificity for sporadic sCJD, and it's been available since 2011. Results are available typically within 24 to 48 hours, and it avoids brain biopsy. In variant sCJD, also known as mad cow disease, all cases were acquired by ingestion of contaminated beef, except 4 cases by blood transfusion from carriers of variant sCJD. The mean onset was in much younger adults, typically in their mid-20s, and mean survival time was longer, typically 14 to 15 months. The clinical findings were different. They were predominantly sensory, neuropsychiatric, but also had involuntary movements. Lab tests that were available at that time were neither sensitive nor specific for the disease. The EEG did not show the typical abnormalities seen in sporadic sCJD, and CSF electrophoresis for 14-33 protein had only about a 50% accuracy. So MRI played a big role in diagnosis. And then in 2017, a new test was developed on CSF known as PMCA. It was tested on bank samples and proven variant sCJD, and has an estimated sensitivity and specificity of 100%. Interestingly, all cases up until about 2015 had a specific genotype at codon 129. They were all homozygous for methionine, no heterozygous and no homozygous valines. Short of brain biopsy, MRI played a huge role in the diagnosis of the variant form. It demonstrated similar findings as the sporadic form, except by location. It had a peculiar predilection to involving the pulvinar area of the thalamus, the posterior medial part of the thalamus, which differed from that of sCJD. It was thought to have a sensitivity of nearly 80% and a specificity of close to 100%. And until 2017, MRI was the single best non-invasive test for the variant form of sCJD. This slide shows the anatomic predilection for the variant form. Note the strong predilection for the posterior and medial aspects of the thalamus on these flare and diffusion weighted images. The epidemiology of sCJD is very interesting. The annual incidence of sporadic sCJD has increased by 2 to 3-fold since 1998. Is the incidence increasing because of better or earlier detection methods? Or maybe it's not all sporadic sCJD that's being detected. As I mentioned before, that all cases of the variant form of sCJD up until 2016 had a methionine genotype at codon 129. And then in 2016, the first case of variant sCJD was proven to occur in a methionine valine genotype, yet the MRI looked just like sporadic sCJD. As I had previously mentioned, up until 2016, all confirmed cases of variant sCJD were homozygous MM at codon 129. But MV is the most common genotype in the United Kingdom. So why did this only occur in the MM genotype? There were two schools of thought for the MM predisposition. First, it was thought perhaps that homozygous MM persons were the only ones susceptible to variant sCJD, and that MV and VV persons were protected. The second school of thought was maybe the homozygous MM persons were most susceptible, but other persons were not completely protected. They were just less susceptible. Compounding this thought was the incubation period for variant sCJD is very long, but it's not known exactly. Some people believe it's 10 to 15 years, other people believe it's 30 to 40 years. So the question arose, might there be asymptomatic MV and VV persons that carry the abnormal prion protein from mad cow disease that may eventually develop variant sCJD in the future and or transmit the protein to more susceptible persons. As I mentioned close to the beginning of this talk, the prion protein is found in highest concentration in brain tissue and in lymphatic tissue. The authorities in the United Kingdom looked at a survey of over 32,000 appendectomy specimens over a 12-year period ending in 2012. And they found that in 16 of these appendectomy specimens, there was the abnormal prion protein, or incidence of approximately 490 per million. 8 of these were MM, 4 were MV, and 4 were VV. So all these patients are asymptomatic, but they carried the abnormal protein. So the question arose, might these people develop variant sCJD in the future or transmit the disease to others via blood transfusion or tissue donations? To compound the worry over this, that a case of variant sCJD was confirmed in 2016 in a heterozygote MV. This 36-year-old male became sick in December 2014. He was referred to the National Prion Center, and apart from his age, the clinical features more resembled that of sporadic sCJD than the variant form. He died in February 2016, 1.5 years after first becoming sick, and when they examined his brain, they found pathognomonic findings of variant sCJD. This case was published in the New England Journal in 2017, and it describes a 36-year-old male who presented with personality change, not dementia. It happened over a 9-month period, and when they did his MRI, the MRI findings were more typical of the sporadic form of sCJD, showing lesions in the putamen and the caudate and no pulvinar sign. Yet, when they did the brain biopsy, it was pathognomonic for the variant form, and his genotype was the first one that was not homozygous methionine, but was methionine valine. And up until this case, 177 cases of variant had been reported in the UK, all homozygous methionine. Then in 2016, this one new case of variant sCJD, which had a different phenotype, and it's estimated that 1 in 2,000 people in the UK are unidentified asymptomatic carriers of variant sCJD based on that survey of appendectomy specimens. So in this article, they say it remains uncertain whether this case marks the start of a second wave of variant sCJD in persons with the MV genotype, the most common genotype in the United Kingdom, mirroring the long incubation periods seen in persons with the MV genotype who have other acquired prion diseases. To summarize, MRI, in particular diffusion weighted images, is an excellent test for early diagnosis. And the diffusion weighted imaging features are characteristic with a very limited differential diagnosis. Since 2011 and 2017, the current CSF tests are very sensitive and specific for the diagnosis of sCJD. From an epidemiologic perspective, the annual incidence of sCJD has increased more than twofold over the past 15 years. So there is an ongoing public health concern that there may be many carriers of the abnormal prion protein and that they may become ill at some point in the future, or if asymptomatic, transmit variant sCJD to others via blood transfusion or tissue donations. If any of you are interested, Dr. Prusner published a book called Madness in Memory, which is part autobiography and part remarkable story of his discovery of prions and the processes that led to that discovery.